seen this morning, there are several different treatments for the humeral shaft fracture. We have seen the conservative treatments, axial bonding nail, placed osteotenthesis, and integral nailing. We've made the choice of the retrograde nailing, which have theoretical advantages like preservation of the rotator cuff and an excellent stability, but also theoretical disadvantages like surgical approach, the patient position, and the proximal locking. So we did our monocentric prospective study from January 2000 to December 2003. We have included 58 successive patients with the mean age was 55 years old. The mean follow-up was about 10 months, and our evaluation was based on the ROMMENS'S score. We have included 54 closed fractures and 4 open fractures. Most of the cases were of the type A of the AO classification. Our nail is the unribbed humeral nail provided by Santes. It's a titanium-made nail which is bent, but you can straighten it or not. Three diameters are available. The surgical technique is quite simple. The position of the patient is described by Ingman, and you can see the picture. We don't use any tourniquet, and we provide a midline triceps approach. We perform an elliptic hole above the olecranon fossa using first small drills, then big drills, and then a specific burr. The rimming was performed in 40% of the cases. Proximal interlocking was made with a radiolucent angle drill. Here you can see the case of a 77 woman years old with a B3 fracture. First picture, preoperative X-ray, and then the postoperative X-ray. The third picture is with a 4 months follow-up, and the last picture with 10 months follow-up. The fracture is perfectly healed. All the patients were included. We don't have any problem with included patients, specifically where they were old. We have to regret 2 deaths before the time of union, and 52 fractures are healed with this primary intention surgery. We didn't have any infection. Our complications were 2 perioperative distal humeral fracture which needed osteosynthesis by plates, 2 preoperative and 3 postoperative radial palsy. Each palsy had recovered within a few months. 1 delayed union and 3 cases of non-union. And we have 3 cases of regional pain syndrome of type 2. With the ROMMENS'S score, you can see that about 90% of the shoulder was an excellent score. On the elbow, more than 90% was an excellent result. Our global functional score were excellent, more than 80% of the cases. We didn't have any loose results on the elbow. Comparing to the other nail, using the southern nail, you can see that the normal shoulder mobility was achieved with 50% of the cases in a Kempf study. Ingman had a study in 1994 with the Grossenkampf nail, which showed only 60% of normal elbow mobility. ROMMENS'S made a study in 1995 with a Russell Taylor nail with 92% of normal shoulder mobility, and Steinhardt, using a flexible nail in 2003, have 1 infection. The treatments of non-unions were simple, with no surgical approach of the non-unions. We use the same approach, the same handle of the UHN, and using this specific device, we can make a compression between the 2 fragments. The healing was obtained in every case in less than 4 months. In conclusion, our theoretical disadvantages were installation, locking, and non-union treatments. These problems are solved, but we do have some issues, which are the difficult surgical technique and the radial palsy and the non-union rates, which stays high to thank you for your attention.